Good evening, everybody. It's my honor and pleasure to share with you today our experience in the vitreous floaters, how to treat them, how to use the YAG laser vitrolysis, and how to deal with them, even with the pars plana vitrectomy and the whole problem of the vitreous floaters. I'm professor of ophthalmology. I'm Ahmed Elmassry, professor of ophthalmology, former head of the ophthalmology department, Alexandria University, Egypt. And I don't have any financial interest of the materials in this presentation. And I would like to thank Dr. Shaima El-Basyouni, who helped me in the preparation of this presentation. To start with, um, to ask ourselves, is vitreous opacities is a common problem or it's not a common problem? Actually, it is really a common problem. This is a photograph that I took for one of my patients with the ordinary 78 non-contact volc and the slit lamp to show how big is the floater, how the floater is bothering this patient as it moves in front of his visual axis and causes a lot of disturbance for him during driving, during seeing any distant object with the clear vision behind. So these are collagen fibers in the vitreous, which may form bundles which can pass across the visual axis as floaters. Over the age of 45, the hyaloid may separate from the retina and float across the visual pathway. So it's called as a vitreous membrane. So one of the key points for the treatment of these vitreous floaters is to have a total posterior vitreous detachment. This is rule number one. So why we should treat or why these floaters to be treated? First, definitely it's a common problem. And this common problem results in patients who are suffering during their work, driving, and reading, and watching the TV and using their computers, and it affects their quality of life. And this is our main issue in this presentation, to assess the quality of life with the vitreous floaters. And again, it's an easy way to be treated for these floaters with the different techniques of whether YAG laser vitreolysis or pars plana vitrectomy. The symptoms of these vitreous floaters, just to be clarified for the audience, that these floating cells, if they are float in the anterior vitreous, they could be ignored. But if they are in the mid or the posterior vitreous, they are definitely visually significant and affects the vision of these patients, as you see, as if you are wearing glasses which are not clean, or these black spots in front of you, and all the image is really not a good thing. Okay, so let's see what are the types of these floaters. We have two types for from our point of view, whether treatable floaters with the YAG laser vitreolysis or non-treatable floaters with the YAG laser vitreolysis, and they have other ways of treatment. So let's see what are the types of non-treatable floaters. These floaters are due to vitreous shrinkage or due to vitreous degeneration or even due to vitreous hemorrhage. Those due to vitreous shrinkage that looks like very small worms that are moving in the vitreous, they are very difficult to be treated with YAG laser vitreolysis, as you cannot focus on these small cells. And actually, even if they bother the patient, you cannot make the patient satisfied with this small floaters. Or if there is a shrinkage in the vitreous, also it is very difficult to be treated with the usual laser treatment. Or due to vitreous degeneration like the syncytial scintillans. All of us know these vitreous degenerations are too much that could be treated with the laser vitreolysis, and these patients, if they are annoyed, the only way of treatment for them is the pars plana vitrectomy. Again, vitreous hemorrhage with all its causes, whether from the diabetic retinopathy or from vein occlusion with a branch or central vein occlusion, or from retinal breaks, the vitreous hemorrhage is not treated with YAG laser vitreolysis, and there are other ways of treatment, like to wait until it subsides and absorb by itself, or to do vitrectomy for cases of advanced vitreous diabetic retinopathy with the proliferative vitreoretinopathy. And so these are the non-lasered floaters, but the lasered floaters, or the floaters that we could be treated with YAG laser vitreolysis, are those floaters pulled off the internal limiting membrane by posterior vitreous detachment. And again, I'm stressing, for any patient who needs to do YAG laser vitreolysis, you should have total posterior vitreous detachment. So the timing of doing the floaters is not immediately once the PVD occurs. We wait not less than few months till the till you are sure 100% that the patient has total posterior vitreous detachment and not partial vitreous detachment, and to be sure again that the patients are annoyed from these floaters and they are not adapted to it. Here we can do the YAG laser vitreolysis safely in order not to pull on the retina or to induce any retinal breaks. So this is more in young myopes. And to start with, in selection of patients, as we are going to describe later with our colleagues, that we have to select the high myope patients, young age or old, the older are better, the pseudophakics, and the small size floater. And the size and the site are also will be discussed. So this young myopes with this vitreous floater could be treated, but of course the percentage of success differs from one patient to another, and all of the time be toward the pessimistic side, having less percentage of success than the expected one. Again, cobwebs also could be treated with the vitreolysis, but they need a lot of sessions more than the expected, as you know, and as will be discussed, we may do from 3 to 5 sessions for floaters to vanish, and each session up to 500 shots. So we never ever give the patient fixed number of shots or sessions, as it depends on their satisfaction. Lastly, if you have an operculum or retinal break, of course, after treating the retinal break with the argon laser photocoagulation, you can treat the operculum with the YAG laser vitreolysis if it moves in front of the patient's field. But honestly, this is a rarity to be treated. These are the types of the treatable vitreous floaters. Okay, patient selection. Again, this point will be discussed, but I'm just describing this point in my presentation to differentiate between the symptoms that the floaters with discrete dark masses, these are the treatable one with the YAG laser vitreolysis, or the vitreous face haze, these are untreatable vitreous floater with the YAG laser vitreolysis, and they need other ways of treatment like the pars plana vitrectomy. And the symptom severity depends on the size of the vitreous floater, whether it's an anterior or posterior location, as had been described before, whether it is central or peripheral, and the personality of the patient. It's very important to stress on the type of personality of the patients. The demanding and the patients are usually, you have to give them lower percentage of success than expected. Okay, patient counseling, again, depending on their expectations, they have to draw the vitreous floater to know what you are treating. And what we are treating is what the patients complain from, but not we are treating something that the patient is not complaining of it. So the percentage of improvement and preparation of the patient, and also, of course, the quality of life of this patient. So the doctor's-patient relationship, when we rule out pathology, we tell the patient they don't have any problem or any disease on your vitreous or retina. Actually, this is good for most of the patients, but it is this advice is apparently a frustrating and unfulfilling experience for patients with vitreous floaters from their point of view. They are feeling something, they are seeing something, and the doctor ignores this thing, and this frustrates these patients. So the subjective experience of sudden floaters is very common after the total posterior vitreous detachment or partial vitreous detachment. And while many patients complain that this is bothersome them, but ophthalmologists tend to pay little heed to these symptoms other than to rule out anomalous posterior vitreous detachment manifesting as either peripheral or posterior retinal pathology or retinal breaks. Unfortunately, once the absence of disease has been assured, the typical eye care professional ceases to be concerned about the issue of floaters. The quality of life is utility values allow an objective quantification of the functional quality of life associated with the specific disease state. So when we say that the utility value or the quality of life is 1, implies a perfect health state, while death has a utility value of 0. The vitreous floaters utility values are equal to the age-related macular degeneration and lower than diabetic retinopathy and glaucoma. So comparing to local diseases, the quality of life is affected as the AMD and glaucoma and diabetic retinopathy. And for the systemic disease, the floaters have lower utility values than mild angina and mild stroke. So floaters have a significant negative impact on the quality of life as compared to ocular as well as systemic diseases. There was no difference between the acute floaters that occur after less than 1 month or chronic floaters, which is more than 1 year for the patients. In both situations, the complaints are the same, and the patients are affected and annoyed from these floaters. The retinal magnification of the image associated with myopia can make floaters seem to be more pronounced. That's why the high myopes are more pronouncing their symptoms than the ordinary population due to the retinal magnification of the image. And there was a study found that these patients were willing to take an 11% risk of death and 7% risk of blindness to get rid of the symptoms which are related to the floaters. And this study, the authors state that the patients with floaters are willing to trade off TTO is a big number of 1.1 years out of every 10 years of their remaining lives to get rid of their symptoms of floaters. So can you imagine that one of my patients told me that he may commit suicide from his vitreous floaters? Another patient who was a pharmacist, he couldn't drive whether at night or in the morning due to the floaters. And after I did him YAG laser vitreolysis, he can drive safely at night and at the morning and the daytime or the nighttime safely. And he was very appreciating the technique and asking why not all the ophthalmologists have an idea or with the YAG laser vitreolysis to get rid of these floaters, which definitely annoys the patient more than the doctors. In conclusion, symptomatic degenerative vitreous floaters have a negative impact on health-related quality of life. Younger symptomatic patients are more likely to take a risk of blindness to get rid of the floaters than older patients. The take-home message: persistent visual floaters can substantially diminish the patient's perception of their life and can be measured by to trade off utility values with high reliability and construct validity. At the end, I can say we are on the right track to treat these floaters by any means, whether the YAG laser vitreolysis or even the pars plana vitrectomy that will be described in the next presentations with my eminent colleagues in the next few hours. Thank you so much.